I invite Dr. Ramurthy sir to introduce speaker, Dr. Periyandavar sir, Senior Consultant Diabetologist.
Dr. Periyandavar does not need any introduction at all. Everybody knows about him. But then, as a customer, I am going to introduce him. He is a senior consultant in diabetology, Tamil Nadu Government Super Speciality Hospital, Omandura Estate, and Professor Institute of Diabetology, Madras Medical College, Chennai. He is a consultant diabetologist in Venkateswara Hospitals and Apollo Proton Center in Chennai. And he is a PhD guide in diabetology at Tamil Nadu Dr. MGR Medical University, and he is formerly chairman, Board of Studies for MBBS and member, Ethics Committee, the Tamil Nadu Dr. MGR Medical University. He is a joint organizing secretary, National Annual Conference, RSSDI 2022, and organizing secretary, DICECON 2011 of Diabetes Association of India, Southern Chapter, organizing secretary, DICECON 2019, GDM Conclave. He is going to give a talk on recent advances on insulin and other injectable forms. Over to Dr. Periyandavar, please.
Thank you very much, sir, for the nice introduction. Respected Dr. D.Diab, Chairman and Managing Director of Venkateswara Hospital. Respected Dr. Ramurthy for giving nice introduction. Respected senior colleagues, my dear junior colleagues, it's my great pleasure standing before you and giving this lecture. This is on recent update on diabetes, on insulin. I have prepared, Dr. Rahul, I discussed with Dr. Rahul. He said most of them are students and those who have started their career, young physicians. So I thought of covering from the basic. Okay. So next to 30 minutes, I will be going about some concept of insulin therapy, okay, which will be useful, I hope. So many thanks to scientific committee. And my agenda of talk will go like this after a brief introduction. Insulin usage in type 2 diabetes, insulin usage in ICU setting, in non-ICU setting, and future insulin therapies modalities available. And you all know, type 1 diabetes, insulin is mandatory. They require insulin for survival. So without insulin, they will die. Okay. So insulin remains the cornerstone of therapy in substantial number of patients with type 2 diabetic patients. Okay. Apart from this, there are many indications of insulin therapy, apart from this type 1 and type 2 diabetes. Among the type 2 diabetes, those who are not controlled with the maximum OHA, so we call it a secondary OHA failure. In spite of maximum oral tablets, we have to give insulin. And in many occasions, transiently, temporarily, we will give insulin. In special situations like surgery, infection, myocardial infarction, any trauma, and sometimes, though its sugar level may not be very high, but with patients, type 2 diabetic patient with very lean, that is with very low BMI at the time of diagnosis. So to enhance the metabolism, because insulin is a growth promoting hormone and it has positive anabolic effect, so we used to give it in the initial stage for a few months to a few years. Okay. So then another main indication for insulin is women with diabetes who become pregnant or breastfeeding. Okay, this is a cornerstone of therapy because now in between some talks were coming about OHA usage in pregnancy, but the latest ADA guidelines and considering the fact that all the OHAs cross blood placental barrier and some studies they go against this usage of OHAs in pregnancy, so insulin is mandatory and good to use in pregnancy. And of course, you all know, in acute complication, metabolic complications like decay, hyperosmolar state, insulin is must and life-saving. And in some chronic complication, amyotrophy, that is proximal muscle weakness. So insulin remains the mainstay, okay? And other complication, microvascular, macrovascular complication, in advanced complication, definitely we work for insulin, okay? And of course, secondary diabetes, secondary to steroids, secondary to other endocrine disorders, other like acromegaly, this Cushing syndrome, the other addition, other secondary endocrine disorders, insulin remains a mainstay. And sometimes some people cannot tolerate OHAs, metformin intolerance and sulfonylurea allergy. There are some patients, so only insulin is the main thing for them. And this one interesting publication, current status of management, control, complication and the psychosocial aspects of patient. It was done in the 2011 study, Diet Care, done by Dr. Mohan et al. And of course across India, many Dr. Shashank Joshi, Dr. Sheshaya, Wagno, Ajay Kumar, Chanjay Kalra, like that, many stalwarts across India. So interestingly, it said only 19% of diabetic patients in India are in good glycemic control. Okay, good glycemic control, you all know, fasting sugar less than 120, postprandial less than 180, HbA1c less than 7. Okay, this is a good control. That's average. So among the, I think 6,500 or 7,000 patients have been studied. So among them 5,200 HbA1c, mean HbA1c is 8.9, and the random sugar that is 140, fasting 147 in 4,500 patients, postprandial more than 200 in 4,600 patients. So, and the worsening thing is average HbA1c of type 2 diabetic patient in India is almost 2% higher than ADA recommended target. So ADA recommended target, it's different for different age group. For youngsters, it will be 6.5, for middle age 7, and elderly people 7.5 or 8 sometimes. Okay, so average this Indian counterparts we have 2% higher from the target. So this is other way of expressing this study done by Dr. Mohan et al. So HbA1c 8.56, fasting 172, postprandial 253. So this is worsening. Even in our practice also, some people it will be very difficult to control. In spite of maximum medication, maximum insulin, whatever the insulin you use, latest insulin, it will be difficult to achieve this target. We don't know what's the reason. Maybe the poor complaint patient will say, Satyamani, I have not taken any sweet. But silently when you probe, the children may say he's taking sweets like that. So this is one part, poor dietary complaints, one part. Apart from dietary complaints and other exercise complaints, there are many other reasons for this poor control in India. So the treatment strategies, that is glucose trial, you all know these three are the main thing. And whenever you aim at HbA1c normal, that is 7 or less than 7, naturally the pendulum will go up. That is hypoglycemia is a very major risk. So we have to be very careful to avoid hypoglycemia, because two things, hypoglycemia is dangerous in cardiac patients, as well as one episode of hypoglycemia will give you some negative impact on your image among the patient. Okay, so you should try to avoid hypoglycemia while treating the patient. And the multiple factors lead to stress hyperglycemia during in-hospitalization, like stress hormones. This I think I will come across a little more. And the main contributory factor in inpatients for the hyperglycemia is lack of exercise. That is, they will be bedridden during hospitalization, and the food will be little different when compared to home food. And psychological factors, infection and financial position. So everything contributes to the hyperglycemia during hospitalization. And this is many studies have confirmed that whenever in hospital patients, when higher sugar levels are going up, starting from, if it is more than up to 120, it's okay. All the non-diabetic patient, diabetes patient, it's a odds ratio for mortality. Okay, death rate. In other words, death rate. So as every 10 milligrams increase in the sugar level, even if it is 140, 150, the curve starts going up. That is, mortality rate goes up. So, so we have to aim at good glycemic control during hospitalization. That will give good success of the patient in hospitalization, as well as it reduces the hospital stay, and of course, the number of hospital stays reduced, then naturally their financial burden will come down So other things. If it is more than 300, you see, it's a more number of mortality is given. That too, already non-diabetic patient mortality rate is little less compared to the newly detected hyperglycemia. So whenever there is already not a non-diabetic or already when they are on good control, during hospitalization alone sugar is going up. What it indicates? It indicates lot of stress factors, stress hormones. Maybe acute myocardial infarction or some surgery, major surgeries, the stress hormones like cortisol, adrenaline and adrenergic, the hormones will be more, so more death rate. Whenever the more settles, so many people in acute CVA, acute myocardial infarction, not a non-diabetic, first time presenting with 400, invariably mortality will be good, high. So it's a poor prognosis, we can say. Okay, very difficult to save the patient. And this one more study published in MICU. This as sugar levels go up, the mortality rate goes up. And this study shows glucose control lowers the risk of wound infection also. So whenever you have tight control, naturally the infection rate will be less, and in poor control, so infection rate will be little more. Okay. So for juniors and students, so this is a normal insulin secretion pattern. You see the blue 3 peaks for every major meal. We secrete morning around 8 o'clock, breakfast 1 peak, and lunch 1 peak, dinner 1 peak. And you look at this lower one, the blue color one, that is baseline. That is, this is blue peaks are called as bolus insulin. This meal stimulated insulin. Okay, depending on meal. For example, for a normal person, if they take 3 idlis, there will be 1 peak. If they take 5 idlis, 1 peak. If they take sweets, more insulin will be secreted. Depending on that, pancreas will cope up with the requirement, cope up with the additional workload of poor food intake. But in diabetics, naturally, pancreas secretion will be blunted. So, but anyhow, there will be some amount of the peak, 3 peaks will be there. Okay. And the blue one is basal insulin. Whether you take food or not, even if you starve for 24 hours, there should be some amount of insulin required for the basal insulin coverage. Okay. So that is the basal insulin blue line. So this is the normal insulin secreting pattern, and this is the main backbone of our therapy during hospitalization. That is basal bolus insulin therapy. Okay. So one basal insulin, 1 shot, and the bolus 3 times. So every meal or every major meal time, we have to give some bolus insulin. Okay. So I will highlight about this various regimes of insulin treatment in hospitalization. So there are available insulin. The first generation conventional insulin era, we lived with those era that is with animal insulin. Animal insulin, there was insulin derived from ox, this horse, and that pigs, that is porcine insulin. So the immunogenicity, antigenicity was more in those days. So we used to give 200 units, 300 units per day, 400 units per day, just like that we used to give. Sometimes insulin syringes those days will not be available. 1 ml insulin, 2 ml insulin, like that we used to give high dose insulin in severe insulin resistant patient. So nowadays it's very rare to see patients requiring more than 100 units per day. Okay, so that's one thing. First generation, that was a conventional insulin. Now we are living in the analog insulin era. There are so many insulin analogs, short-acting analogs, long-acting analogs, which is simplify the things, and newer analogs, that is D.Diab, 2GO, like that. So many things are available. So these are the rapid-acting analogs. Those aspart from Novo, Lispro from Lilly, and glulisine from Aventis, and long-acting detimir from Novo, Glargine from Aventis. And nowadays many companies are coming with Glargine, and Diabetologist with Novo, and premix insulin. This even today across the world, this is number 1 prescribing premix insulin. It's in the ORG survey. This is the top one, premix insulin, 3070. That's the top one. And of course, other companies also, they have their own thing. And the latest hit is co-formulation. That is one short-acting analog with long-acting basal insulin, analog insulin. That is Diabetologist. Okay. So for students, so in some patients we will write 30 minutes before food, the insulin should be given. The reason behind this, insulin, available insulin, the regular insulin is available in hexameric form. In neutral pH, pH 7, insulin will occur in either hexameric or dimeric form. Okay, it cannot be absorbed. So you see the capillary membrane. Any pointer? So this is the capillary membrane. So it will, the pore, the size of pore will be very small. So hexamers cannot enter into the capillary membrane. Only the hexameric insulin, it should be dissolved. So they will be disintegrated into dimers and monomers. Some dimers will be absorbed, mostly monomers will be absorbed. So from hexameric form to conversion to monomeric form, it will take 20 minutes to 25 minutes. But the analog insulin, they are different. They are straight away they are available as monomeric form. So the advantage of analog insulin is straight away we can use it. So just before food or along with food, even the fast-acting insulin we can give it even immediately after food also. So they claim, pharma people, they claim even up to 20 minutes after food also that fast-acting aspart can be given. So like that. So these are the advantages of this analog insulin. And for students, I will tell you some of the regimens which you use popularly. This is a once-a-day insulin regimen. Either it's a 30-70 preparation, 30% short-acting and 70% long-acting. Okay, all the companies, they have one 30-70 formula, and some companies for the postprandial peak to reduce it, 50-50 formula is also available. Okay, so if post-breakfast is high, we give 50-50 so that you can control effectively the postprandial hyperglycemia. So this is a once-a-day insulin. And other twice daily insulin, same 30-70 preparation as well as 50-50 preparation, you can give is twice daily insulin. This is a second regime. This is also very popular almost all patients. Well, majority patients once a day insulin we cannot achieve the control, but twice a day most of them will come to control. Almost 60 to 70% people will get come to control with this twice daily pre-mixed combination, either 30-70 or 50-50. So this is one good thing. And the third one is long-acting insulin analog. That is, I told you, Glargine, the Detimir, and the latest with the Gludec. These three are the long-acting insulin analog. Any one of these, once a day. So this is natural insulin, and this blue line is once a day insulin. Just, for example, fasting sugar slightly above the upper limit, postprandial slightly above the cutoff value. So we will be in a fix. Whether you use short-acting with this pre-mixed insulin, patient may go for hypoglycemia. You can safely give this long-acting insulin. Okay, analog. And many of the slides have been taken from this practical aspect of usage of insulin in India and the descriptive review on the key recommendation. Okay, so the recommended glycemic target the junior should not do. So we cannot aim at a normal sugar level for the inpatients or in hospitalized patient. So normal, you all know, fasting sugar less than 100 and postprandial less than 140, which we should not aim at. So it should be relax. Almost all the bodies like the ADA, EASD and this American Association of Clinical Endocrinology, everyone relax. So fasting can be up to 130 and the postprandial can be up to 180. So in elderly people, it's still further relaxed. Fasting can be up to 140 and the postprandial can be up to 200. So like that, depending on age group, the criteria is. So then I will come across next couple of minutes to how to initiate and how to intensify the treatment. Okay, so how to initiate treatment. So initiation of treatment is dose titration to ensure that the patient receives maximum benefit from the prescribed treatment. After initiation, start with a minimum dose, either pre-mixed insulin or the basal insulin. You have to optimize the treatment. So what's dosage we have to optimize, and finally after a few weeks they have to intensify the treatment. Okay, this is what the routine thing we have to do in our practice. So modification of the insulin regimen, adding or changing the therapy in order to maintain the glycemic target, okay, which I have mentioned already. Okay, so there will be, you all would have noticed once you start the treatment, so there will be progressive increase in insulin requirement. First few months you will be requiring, patient will be requiring 10 units or 15 units. After 6 months or 1 year, they will be going for another 20 units. First initially once a day, then after 6 months twice a day, or then 3 times a day, like that. So these are the, because diabetes is a progressive disease, and that is the one disease factor. Irrespective of our lifestyle changes, your good control, good compliance, pancreas is worsening. So it's a periodical progression of disease. And the patient factor, this you all know, is just for completion check for students. Poor dietary compliance, improper exercise, irregular insulin prick, improper injection technique, and insulin vial syringe mismatch. Sometimes patient will be taking with 100 AU syringe with 40 AU preparation. So even if you put 30 unit sugar will not come down. So once you go for 60 units, then it will come down. But originally, if you are giving 60 units, patient will be getting only 20 or 25 units originally. So the insulin syringe is very important thing. Even some time back, we found out in some of the government hospitals, 100 AU syringes were supplied. We found it very difficult. Once we enter into the ward, then only we have noticed that the staff nurses were using 100 AU syringe. Then we stopped from the central supply, TNMSC, we stopped that 100 AU syringe. So these are the common thing. And the improper storage of insulin, the cold chain, if it is not maintained, insulin will not act. Okay. So stress and infection and other factors. So this is a typical insulin journey in insulin recurring patient. So first few years only lifestyle changes and OADs. So after that, once OAD fails, we have to start the insulin. That is initiation of insulin with basal insulin plus continuation of OAD. And after a few years, you have to optimize, few months or few years, optimize insulin therapy. And finally, once pancreas exhausts further, so we have to intensify the treatment. Okay, with the twice daily or thrice daily insulin regimen. So titration inertia. So many people will ask so many questions. So patient will do so a lot of things. Patient will take a lot of sweets, that juices, Pepsi, Coca-Cola, like that. Everything they will do. But ultimately they will come to, sir, whether this tablet will produce side effects. Sir, whether I have seen in the net, sir, this producing some gangrene, sir, in the scrotum, sir, who you have prescribed, sir. So like that, so many things we are facing. Okay. So like that, insulin causes harm. Even with the gestational diabetes, when, sir, you have prescribed insulin, whether it will help my baby, like that. So patient sugar will be 200, 250. Anyhow, if you don't give insulin, baby is going to get affected. But they will think it's my insulin dose, whether it's, they will have prevention. So, is it difficult to integrate insulin into my daily life? Titration algorithm, I think dose increase mean worsening of disease. Individuals with the diabetes may perceive insulin therapy as an indication of failure of life, like that. So many things we come across. So, how to overcome this titration inertia? The insulin with the well-established risk of hypoglycemia. Because many a time, once you start with a very high dose of insulin, patient goes for hypoglycemia symptom, then they will have panic, fear complex for this insulin. So always choose insulin which will, like basal insulin, which will not produce hypoglycemia. First get confidence from the patient, then you can slowly up titrate. And simple and easy to follow titration algorithm. So almost all the guidelines, ADA, ASCE, IDF, Canadian Diabetes Association, UK NICE guideline, RSSDA, Indian Endocrine Society of India, everything, first to start with the basal insulin, that's what the guideline says. Then optimize. Sometimes the basal insulin may not be sufficient. Some people, we will start with the premixed insulin, which is very popular in our country. So basal insulin may not be effective. So some people we choose the premixed insulin. But the guideline says start with the basal, then uptitrate, that is intensify with the premixed insulin. So basal insulin is well established risk of hypoglycemia and 50% lower risk of overall hypoglycemia with the basal insulin versus premixed insulin. This has been ascertained by many studies. And individual pharmacological profiles of basal insulin. So this NPH, the gluten, this everything, onset of action, these say students, say beginning practitioners, you should be very thorough about this pharmacodynamic and the pharmacokinetic properties of insulin of various preparation. So short acting, duration of onset of action, peak of action, duration of action, frequency of administration, like that. Once you are thorough with it, then it will be easy to titrate the insulin dosage. So basal insulin start, how to start. So it's like if A1C is less than 8, that is borderline, then start at 0.2 units per kg of body weight. If high HbA1c, it means there will be some amount of glucose toxicity. What is glucose toxicity? Chronic hyperglycemia producing some sort of insulin resistance. Okay, the glucose toxicity is high, so you require more insulin. So 0.3 units per kg per day. Okay, this is a starting dose of basal insulin. Okay, but depending on the body weight, also you can just have some titration. If lean individuals, you start your HbA1c is 8, so 12 units. Just don't calculate with this 0.2, 0.3, forget about it. Just to start with 12 units of glargine or Deglutec or your detimil, okay, any long-acting analog. So if HbA1c is more, you can 16 or 8 units in lean individuals. 80 kg, that is obese individuals, morbid obesity. You can give 20, 30 safely. Okay. So depending on the weight also, you can choose the insulin dosage. So some for this one guidance for starting with the basal insulin. So when to stop insulin? So if it is not effective, naturally we cannot continue the basal insulin for a long time. We can wait for 1 month, 2 months, 3 months. Then if it is not effective, change or add some other basal. Stop taking basal insulin, add prandial insulin if a patient is unable to achieve HbA1c target. Okay. And the A1C goal, despite the targeted postprandial levels persistently above high, basal insulin alone cannot be effective. Okay. So we have to add bolus insulin. What are the bolus insulin available? So conventional, very cheap, still we are its backbone of many middle class people, regular insulin. So onset of will be within half an hour, 30 minutes it will start working, and the peak is 1.5 to 3.5 hours, and the duration will be, duration is 7 to 8 hours, but depending on the renal parameters, if renal function is very weak, renal failure patient, this will be little prolonged. Okay, always beware of prescribing insulin in CKD patients. Okay, and the insulin aspart 10 to 20 minutes, and it start immediately. So peak is 1 to 3 hours, duration 3 to 5 hours. Lispro, all other blue lights, these are all short-acting analogs. Okay. Then intensifying with the prandial insulin, the fixed single bolus dose of 4 to 6 units administered with the largest meal of the day is the ideal one, in addition to the basal insulin. A dose defined based on the levels of postprandial glucose value in millimole divided by 2. This is the one formula of getting the insulin dosage. A dose based on previous basal dose, that is 10% of basal dose you can allot for this bolus insulin. Okay, if it is you are giving 20 units, then 10% each, 2 or 3 units you can give as a bolus dose. A dose based on patient's weight also 0.05 units per kg, that is a bolus dose we can choose. So there are many options to intensify. From basal, you can go for basal plus. Basal plus is one basal insulin plus any one time one bolus insulin, either with a major meal. If post breakfast is high, you can give the insulin, bolus insulin in the breakfast. If it is post lunch is high, you can give post lunch, before lunch you can give one shot of insulin. Okay, and from basal regimen, you can go for twice daily premix, thrice daily premix, split mixed insulin, like this. So we will go one by one some of the regimes. This is a basal plus. So look at this, one basal shot, and plus is one bolus. Either after breakfast, before breakfast or before lunch, anyone you can choose. So dosing, when basal bolus regimen is one bolus, this already we have seen. Yeah. So this is a basal bolus. It's a typical physiological insulin regime. So it's a one basal insulin along with 2 or 3 rapid acting insulin regime. It's the gold standard of insulin regimen for all patients. However, the difficult control you have put this, they will be under good control. So dosing, how to calculate this insulin requirement for this basal bolus? The calculation of total insulin dose is done as 0.3 to 0.5 units per kg body weight. That's the total insulin requirement you have to calculate. Okay, 40% of total insulin dose is to be given as basal insulin. 40% basal. Single dose at bedtime or morning time, whichever is convenient to the patient. Remaining 60% of total dose is given as prandial insulin divided in 3 doses. Before breakfast, before lunch, before dinner. So these were the calculation. So advantages I told you, potential for better metabolic control and closely mimics normal physiology is what I told you already. And the disadvantages, poor compliance, problems of hypoglycemia and weight gain, needs full patient motivation, requires regular monitoring. And this is a twice daily premix population regime. This already we have discussed. This is very popular across the world. Will control fasting and the post-bolus before which it is injected. So this is the curve pattern in the twice daily premix insulin. And the advantage, easy to learn and implement. Compliance is better twice daily. If you give 4 times insulin, patient will be, first time they will agree. After 1 month they will just ask 4 times what's lifestyle, 4 times you are telling us good thinking. So like that the compliance is better with the twice daily. Disadvantages, fix a daily routine, that is lifestyle, they have to compromise. Okay, if they delay food intake, they will go for hypoglycemia. So it should be very strict, and carbohydrate content, meal timing we cannot change, it's not flexible. Okay. And the thrice daily premix insulin, this is actually we are against it, But some people, they use the premix 3 times a day. Morning 30-70, afternoon 30-70, night 30-70, but it's, we feel it's not good. But based on one study, there is one clinical trial conducted, 1, 2, 3 clinical trial. So 1, 2, 3 clinical trial, they find good control after this 3 times 30-70. So based on that, some are using this 3 times 30-70. And this is a split mixed regime. This is a typical our GH prescription, okay? R15, N10, or R10, N15, depending on the postprandial, depending on the. So afternoon we will not give to give better compliance. So night R10, N20, like that, depending on post dinner, depending on the post lunch. So we will titrate the N dose, and N is NPH, R is regular, okay? Short acting and intermediate acting. So we have the amounts of intermediate and short acting or can be adjusted independently of each other. The 2 insulins are mixed by the patient. And the insulin regimen, the overview of efficacy and safety, the basal bolus, fasting blood glucose better, or postprandial better, insulin dose, hypoglycemia is very less, weight gain is little more. So premix fasting sugar, it's very difficult to control. Postprandial little better, basal insulin, fasting little better, but postprandial you cannot achieve good control with basal insulin alone. So let us see what do these ADA guidelines say. So the majority patient, they recommend basal plus. So after if basal insulin fails, you add one more plus the bolus dose after the major meal. This we have already studied. And this ESI, that is Endocrine Society of India, and the RSSDA, the titration recommendation, they have given it given in the net. You can just choose it. And this the same thing, the various formula. When fasting sugar is high, you increase the titration dose by 4 units, decrease like that. It's a simple titration. This usually you will come across after usage of this insulin, this regime in your practice. So always guidelines are there. It cannot fit into all the patients, so it should be individualized. So some patients require individualized treatment, not this guideline alone. So now I will concentrate on some of the in-hospital management. So pathophysiology of hyperglycemia, this is after any hospitalization, there will be increased counter-regulatory hormones, corticosteroids, catecholamines, glucagon, growth hormone. So adipose tissue, increased lipolysis, increased free fatty acid liberation, and protein breakdown, amino acid lactate. Everything goes to increased glucose output, that is hepatic glucose output, producing hyperglycemia. And moreover, our iatrogenic IV dextrose glucocorticoids will be giving, and catecholamines, inflammatory cytokines, total parenteral nutrition, which contains 28% of carbohydrate, that is dextrose. So when our patient is on TPN, it's very difficult to control diabetes. Enteral nutrition, that is in some ICU patients, they will be giving continuous range tube feeding. It's very difficult to control. If you give second hourly range tube feeding, it's okay. But continuously means continuously the pancreas will be exhausted, pancreatic exhaustion will be there, it's very difficult to control. And other volume depletion, hypoperfusion, tissue effects, reduced nitric oxide, superoxide separation. Ultimately, some patients go for sepsis, multiple organ failure. Okay. And during hospitalization, these are the obstacles for us in achieving the good glycemic control. So one side steroid, patient will be on nil by mouth, and patient dialysis, total parenteral nutrition, tube feeding, steroids. So many things which interfere in our regime. So we should have close watch on this in hospitalized patient. And previously in our student days, the sliding scale insulin will be based on the urine sugar. So urine sugar 1 plus you give 10 units, urine sugar 2 plus 20 units, urine sugar 3 plus 15 units, like that some regime will be there. So it was outdated 3 decades back itself. Now then came based on the CBG reading or based on the sugar level. If sugar level, blood sugar level, if it is between 100 and 150, you give 5 units, 200 to 250, like that some fixed dose, sliding scale. So sliding scale is strongly discouraged by all the bodies, including ADA, the ASD, and the AACE, American Association of Clinical Endocrinologists, everybody. So it promotes roller coaster and cannot predict insulin dosage requirement. Okay. Whereas this basal bolus insulin regimen in hospital patient, it's a physiological way of glycemic control. It addresses all the 3 components: basal component, bolus component, correctional component, everything. So ADA recommends use of basal bolus regimen in inpatient setting. Not only ADA, as I told you, all other we have already studied. And evolution of management of IP hypertension, previously 3 decades back sliding scale insulin and 2 decades of basal insulin alone, then now basal bolus therapy. Okay. So with in those our student days we had only NPH, which is considered as a basal insulin. Now then came Glargine, then came Detinib, then Glargine U300 is ultra long acting, then Degludec. Now it's a Degludec which has 36 hours of life. So like this animal insulin for bolus insulin also. Previously we had animal insulin, humanoid insulin, human insulin, analog insulin, and now fast acting insulin analogs. Okay. So in hospital settings, in any hospitalization, OADs are not generally recommended. This is a universal accepted form because almost all OADs, patient will be in a different scenario. Patient will be given with some antibiotics. The patient will be having a poor food intake owing to the illness. So metformin usually we will avoid during hospitalization. And of course, other when pancreas is under tremendous exhaustion, sulfonylureas cannot be given. So only thing DPP-4 inhibitor, sometimes some studies they say, but in general, avoid OHS in hospital patients. Insulin is recommended, and IV insulin in critically ill patient. Critically ill patient treatment is very simple. Give the insulin infusion protocol, then it will be going on. You need not bother about it. Only the other non-critical patient, only subcutaneous insulin, you require the expertise. Okay. So this is IV insulin protocols. Every hospital follow, every ICU follow different protocols. For example, Yale protocol, Leuven protocol, University of Washington, the D.Diab protocol. So there are many protocols you can get from the net. So you can use it for in-hospital patients. So I will how to calculate this insulin for this through this case study. Mr. S is sugar level 410, urine ketones positive. It's a typical bicarbonate level 12. It's a typical decay. Okay. So decay, we have to choose some insulin infusion protocol. So this is a common protocol which we use it. So insulin preparation, so regular, so 50 units regular in 50 units normal saline, or 40 units regular in 40 units normal saline. So dosage depending on this sliding scale. So if it is 250 and 299, 3 units, 300 to 349. If you tell initial few hours hourly CBG and titrate according to the schedule. And if after 12 hours or after 24 hours once stabilized, you can check second hourly CBG. So flows monitoring is important because sometimes patient you will be doing only with CBG. Okay. In septic shock patient, there will be hypotension. So tissue perfusion will not be there. Always you will have what? When you have CBG, it will be low, 80, 70. So you think of giving glucose stopping insulin. But when you say you check venous sample, but it will give high value. So you have to calibrate periodically with the venous sample with the glucometer reading. Okay. So these are the things. And a few minutes, I think it's diabetes and surgery. So during surgical management, so main thing anesthesia, infection, stress, these 3, 1, 2, 3 can cause metabolic changes during surgery, and it's a teamwork during surgery, intraoperative, postoperative, perioperative, everything it requires. So diabetologist, physician, surgeon, diabetic nurse, diabetic trained nurse. Because some new nurses, if you are not exposed to things, they don't know about the importance of short-acting insulin. They don't know importance about the syringes which you give. Okay, even the second level CBG, they just ignore it. Okay, so only diabetes trained nurse, that is very important. Success of surgery depends on close team. Team is together, each one achieves more. And surgery in diabetes, the type of diabetes we have to so. Metabolic status, vascular status, everything we have to look into, whether it's emergency surgery, elective surgery, minor surgery, so type of anesthesia, everything we look into before prescribing insulin dosage during surgery. And in some cases of cellulitis, gangrene, we require very intensified therapy from the start itself. So if you just miss the bus, then the patient will have, by virtue of poor immune function, the infection will get worsened. So some ketogenic infection for uncle, so we have to check acetone. Okay. So for every surgical patient, we should check acetone. If ketones are positive, if you intervene early, you can prevent acidosis. Ketosis is different, ketoacidosis is different. Many people will think urine acetone trace 1+, they will say decay. patient will be very much stable, sugar will be 250, 240 only. So if you say the confirmation of DKA, you should know 3 things should be achieved. One is hyperglycemia more than 300. Second is ketone bodies present either in the urine ketonuria or blood ketones, plasma ketones. Third is acidosis you have to document. Either PS should be less than 7.2 or bicarbonate level less than 15, some books say less than 12. This documented acidosis, then only you can classify the patient as DKA. Many times they will say just ketones positive. Ketones positive may be there in starvation ketosis or even this SGLT2 inhibitors, you will get ketones positive in the urine. So we cannot just like that say DKA for all the ketones positive. So it's self-limiting most of the time. So for anesthetist, we have to give tips. Surgery usually in the morning time we have to prefer. So surgery preferably in the morning time because no fear of hyperglycemia, no fear of hypoglycemia. So if the patient starves, if you post the case in the evening, from morning patient will be in starvation. When he is awake, so naturally he will be hungry, he will be tired, he will be more. So patient may go for hypoglycemia. So early morning after overnight fasting, if you go for surgery, it's good for the outcome is good in some of the researches. Okay, so instant possible. So anesthetics and daycare procedure. It's just like minor surgery with good glycemic control. Admit 1 day before surgery. Major surgery admit 2 days before surgery. Okay. So this is one among the major studies published in the recent era. It's a UK study, nice sugar study. That is largest study to date. Normoglycemia in intensive care education, survival using glucose algorithm regulation. So it's in critically ill patient. It was done in the 6,104 critically ill patient. The 90-day mortality was significantly higher in the intensively treated versus conventionally treated group. Mortality from cardiovascular cause was more common in the intensively treated group. So don't aim at 110 milligrams, 100 milligrams, 120 milligrams. So during this critically ill patient, always relax. Keep it around 180. So in the empty stomach, keep it between 150 and 200. And after the meal or anything feeding, feeding, you keep it just around 200 or just above 200. Okay, this is what the nice sugar guideline says. So other aspect you all know. Once you say insulin, patient will be panicking. Patient will be there. Rather than patient attenders, sir, leave him now. I will control panirana. So avoid insulin, sir, like that, everything. So there's a barrier cost of initiating therapy. And so there are some alternative route of therapy have been mooted, but everything failed. Okay. One is peroral enteric, that is insulin capsule was tried. I think when I was a PG student in 1990 or 91, at the time in the Apollo Hospital, one unit was Sindhuri Hotel. Now Sindhuri Block, there is a hotel, 3-star hotel. In that hotel, one big conference was, international conference was coming. It was organized by Dr. Sheshia. So one scientist from USA, he came. At the time, still my memories go to that. One scientist told, we are on the verge of inventing oral insulin. Anytime it will hit the market like this. He told me 1990. So still, every conference, same words are told by some other people, those who are on the research. So, but still, the oral insulin is still mirage. Okay. So oral buccal insulin, it came. Actually, I think Shreya, one company there, I was also part of that clinical trial, buccal insulin trial. So it was good, but we had to spray, oral spray. One spray is equal to only 1 unit of short-acting insulin. For example, 10 units patient is we have to prescribe. So 10 times we have to spray. It's very expensive. One spray is $1. So 10 spray means $10. So it's almost 800 rupees one shot. One. So like that it was but that absorption was erratic in our Indians. So some people will have thick, those who are using the palm and this betel nut and this tobacco, they will be very thick because absorption is very less. For some people, some ladies, they will have good absorption with the 3 puff they are able to control. Like that inter-patient variability, so it was not able to come to the market. So they tried rectal insulin, they tried ocular insulin, intravaginal insulin, transdermal insulin, nasal spray, so everything failed. Pulmonary route also they tried, everything failed. Okay, and this one Dr. Rahul wanted so alternative route of insulin injection. This is a typical insulin pump. So now closed loop pump, they have like artificial pancreas. Now they have come out. So one side there is sensor. The sensor, it senses glucose level. Through Bluetooth, it reaches this insulin pump. So depending on the insulin level, prevailing level, it's programmed to give insulin. So you need not titrate any dosage. Depending on sugar level, it will release some amount of insulin. Okay, this artificial pancreas, now it's available in the market. So this is just a hand. It's a very small unit. I think they charge around 6 lakhs to 7 lakhs.
Is it successful?
Yeah, yes, madam. It's many people they are using. So it's a good thing, but consumables every 3 days 3,000 rupees. 3,000. That tubing is very expensive. So every month you have to spend at least 30,000 rupees. Every
Apart
month.
from 6 lakhs initially.
Apart from the initial investment, the 7 lakhs. But those who are having severe insulin resistance, those who are their lifestyle is very good with this pump. So it's the only thing cost. I think we have to learn the art of printing money. So such a cost. So it's a very simple, easy life is very comfortable with the insulin pumps. So other things, this insulin pen fills, pens, these are all, many people like pens. Some people they don't like pens because it's a difficult pen. I have seen some people have pen is not, though it's a fancy glamour, but it's a you give much pressure. To overcome this, I think Novo has come down with the flux touch. Just you touch one touch, it will go. It will produce some this action. So like this is no needle injector. Okay, needleless injector. So it produces tremendous amount of pressure inside that. There is a like gun. You put it in the thigh, just like a gun, release the trigger. So with high pressure, insulin enters into the subcutaneous, that is transdermal. So this is the mode. So you see this instrument. Painless. No. Pain will be there because it pierces the skin. Look at this. This is a common injection site. Subcutaneous insulin reaches. So here with high pressure, when it reaches this dermis subcutaneous region, insulin goes like this. So when with the high pressure goes in, there will be some sort of pain. It's not like a pricking pain, it's some sort of pain. Some 70% of pain like needle will be, so only it's not popular. It was 25,000 one unit, apart from insulin cost. So even after giving 25,000, I am getting pain, why I should purchase like that. It was not, and that too, depending on skin thickness, delivery is not predictable. So insulin 5 units, now you are sure, 5 units go to the body. Here it was not sure, so like this. And this Exubera is a powdered form of recombinant insulin. So like this, so to conclude, diabetes is a progressive disease over the period of time. Insulin intensification becomes imperative. Insulin intensification can be done with regimens like basal plus, basal bolus, twice daily, thrice daily premix insulin. And each regimen has its own advantages and disadvantages, and choosing best regimen should be individualized according to lifestyle, literacy and food habits of patient. Close monitoring, that is very important. Okay. And timely titration to avoid hypoglycemia. And hospitalized patients are at high risk of adverse outcomes and mortality, more chances of infection if diabetes is not under control. And the short-acting insulin decreases postprandial, long-acting insulin decreases fasting sugar. And always think insulin is a double-edged weapon. It can produce weight gain, it can produce hypoglycemia. It is atherogenic. Hyperinsulinemia is atherogenic. So with this I conclude my talk. Thank you for your patience. I welcome you all for this 50th Golden Jubilee National RSS Day Conference. After 10 years, 2012 we conducted in Chennai. Now it's 2022, it's coming October 5, 6, 7, 8. Thank you thank you Dr. Pillai sir for giving me.
Sir, the one problem we face is dentists normally refer cases to us.
Yeah, it's open for discussion. I'm having one more meeting.
They ask us to reduce, day after tomorrow we go removing the tooth, reduce sugar and send in, they say. It's so difficult, he'll have 400 sugar, how can you reduce this?
Sir, we should explain to the patient, it's very difficult, it will take another at least 1 week. Sometimes, if there is dental abscess, this severe pyorrhea and this gingival abscess, even if the 400 you can do that extraction. Once you do the tooth extraction, sugar level will come down within 2 days. So we have to explain, we should talk to the dentist. If it is impending abscess or severe abscess, already known abscess or severe infection, you can go with the procedure. After all, they are going to give local anesthesia, but it's risky only. But other things you have to check. You get one cardiology, fitness cardiology, do one echocardiogram, do one ECG, so that you can relieve your stress through the cardiologist. So they will also take responsibility. So like this, to do something to the patient, because unless you remove the pus, it will not. Very difficult to control. Even with 3 times insulin basal bolus therapy, it's very difficult to control diabetes.
Right.
Question and answer session for 5 minutes. Anybody have any questions?
Regarding the, you were saying that insulin is meant for pregnancy, control is insulin. In the UK, they do use metformin for.
Metformin, sir, but metformin actually we have been using it for many decades. Okay,
Yeah.
But outcome, if you say insulin has very good outcome. That's my personal use, my professor's use, guidelines, and actually metformin small dose, no problem. But if you give 1 gram twice daily, naturally there will be a UGR. You see the birth weight and other things. There are many people for study purpose, for research purpose. So many papers are coming. They will give metformin outcome is good. Offspring they don't get diabetes like that. So these are all things.
Also, prematurity doesn't increase with metformin. Premature births.
No, we cannot say like that. UGR was documented in many Australian studies in the initial phase, in the early 2000s. So UGR and high dose metformin. Okay, so that's the thing. And rather than metformin, one thing we should do, even trivial hyperglycemia is teratogenic. This point is very, very important. For others, other guidelines says for other illnesses, fasting up to 125, postprandial up to 180, 120. But universally, you see all the guidelines, fasting should be around 190, 92. Only one guideline says 95. That I think EAD, PSD. All others says 90, 92 only. Postprandial 120, irrespective of all the guidelines. Because even the slight 5 milligram, 10 milligram high sugar level is teratogenic. So nowadays, to conceive itself is a very great thing now. Lot of infertility clinics, see, springing of so many infertility clinics because of the poor lifestyle. Okay, so once conceived now, if they recurrent the fetal loss, so it's a strain for the pancreas. So if you want to give good outcome, start insulin at the early stage.
And another thing is, if a patient, I have actually a patient now who's planning pregnancy. In that stage, is it okay to give metformin?
No problem. You can give it.
Pre-pregnancy,
Yeah, you can give.
safest will be.
Yeah, you can give metformin. Provided you should achieve the target. If sugar is high, first trimester hyperglycemia, definitely it's going to get your fetal vestige. Yeah. Because first 6 weeks to 8 weeks, the heart development will be there. So it will be some cardiac malformation will be there if you don't control and. There are some exceptions. We have seen 300, 350 milligrams in the first 3 months, 4 months period coming out very smooth outcome. You cannot compare with others, but majority.
The reason for this increase in infertility is also because of this pollution, the plastic and other.
It's a lifestyle, no filthy lifestyle. It's not it.
Obesity.
Obesity, not obesity. Obesity is the lifestyle disease. So irregular timings, irregular sleep, Dr. Thiles had the initial phase told. So irregular sleep, irregular thing. And some people really, they hard work, they work until midnight. Some people just watching WhatsApp, watching the Facebook, they awake until midnight. So many things, no exercise. This sir told about Maida, no sir, Maida. What's the thing? Baroda, etana baroda kada, etana biryani kada, mushrooming of these things. All conduct a reusage of oil, all trans fat. So only.
Thank you, sir. Thank you very much.
Thank you, sir.
So, 1 second.
I request to Dr. Ramamurthy sir to honor our speaker.
Please. On behalf of I think it's a